positive end expiratory pressure. You want to maintain pressure inside the thoracic cavity even when the patient exhales. So it keeps all of the alveoli open, it helps with oxygenation. So you want, if the patient is on PEEP, you're not going to take them off PEEP. You want to make sure that you keep them on it. These two are adjustable. They have a spring, so by turning it down or turning it up, you can adjust your level of PEEP that you're applying to the patient. These are preset. They're all what we call spring-loaded. They're what we call threshold resistors. These have the numbers that you're going to need written right on the top. For example, this is a 7.5, this is a 10, this is a 12. So you have different levels of PEEP. So depending on what that hospital uses will depend on what kind of PEEP valve you have in that hospital. The spring one or these are the ones like this.
Mary, you said they were called spring-loaded or what?
Threshold resistors. What you need to know is where is the exhalation port on your manual resuscitator so that you know exactly where to put your PEEP valve. For example, this one, the exhalation is up here. So your PEEP valve has to go up here.
Where your exhalation port is?
Right. Positive end expiratory pressure. You're applying back pressure during the expiratory phase of your cycle. So with this one, it would go up here. The same with this one. It's on the top here.
How does it actually work?
It has a spring-loaded back pressure in here that actually prevents the patient from completely exhaling.
Oh, so it keeps some of the pressure. Ah, okay.
So it's like when they exhale, it's instead of like blowing everything out, like it kind of holds it back.
It's kind of like, let's say if you were pursed-lip breathing, you're always going to keep a little bit back pressure in here to keep things open, but this holds that pressure in there and it never completely goes back to atmosphere.
Aren't all patients that are mechanically ventilated, don't all of them always have PEEP?
I would say 95%, yeah. There are a few that don't, but very rare. But a lot of times it will be what we call physiological PEEP, which is 3 to 5 centimeters of water pressure. But sometimes the patient needs much more PEEP because they're having trouble oxygenating. So you may see, 7, 10, 12, even as high as 15. I've seen as high as 20. With this one, your exhalation is here. So this one comes apart, so you can, adjust it to whatever you need to put it. These don't come apart, so if it doesn't fit, you may need some kind of adapter.
What's the other port on there with the red top?
Huh?
What's that red top?
I'll get to that
Okay.
in a sec. So you need some kind of adapter, like this one doesn't fit on here, so you might use a gum rubber adapter, or you might, I would put a gum rubber adapter to get this one to fit on here. You remember our gummies? Gum rubber adapters are kind of respiratory therapist's best friends.
Have we ever talked about this?
No.
No, but I think I've used them on just about every lab we've done.
That's the first time.
You remember when we did manual resuscitators and we used these things to get, not manual resuscitators, but right respirometers to get everything to fit? They're gum rubber adapters. They fit on just about everything, and you can attach just about anything to everything with them. They're not anything technical. They're just
Adapters.
things to help you. Okay, so this is your different version of PEEP valves. Now, what you were asking about, the red thing on here, which is also what's on here, on here, that's called your pressure relief valve, or we call them pop-off valves. This is so you don't apply too much pressure. Now, this one can be opened or closed. Right now I have it open. I'm going to close it. And when I'm applying pressure, I can only apply, I can apply as much pressure as I want. But if I open that, and I'm applying too much pressure, it vents the excess pressure to the atmosphere. This one is closed when I have that in there. But if I open that, it vents that excess pressure
So
to
is
the
it good
atmosphere.
to have it open?
Huh?
Is it better to have it open?
No, we never have them open. We always have them closed.
Why would you want it open? Like on a baby, if you had to use an adult one on a baby?
That would probably be a reason to open it if you use an adult one on a baby. But any hospital where you have the possibility of a pediatric community, even in the emergency room, I promise you, you will have either pediatric and or neonatal bags somewhere in the facility. Even if you work in a hospital where you don't, as a rule, have pediatrics, in areas like the emergency room, they would make a point of having those bags there just in, I mean, you never know when there's going to be an automobile accident and they bring in a 2-year-old. You know, so they want to always have those bags available to you, just in case that
Where's
occurs.
the oxygen hooks up? Where the tubing?
In this one, the oxygen was hooked here.
And that'll just lay
This
in
is
the
your
patient's
reservoir
bed.
bag. Huh?
That'll just like be like the small tank that lays in the patient's bed.
That
or-
depends.
If that's
Usually, if you're in a
transported.
code, you hook it up to the wall.
Right.
Um,
If you're transporting the patient.
the only time you're going to let it in the bed is if you're transporting the patient. But this is going to be hooked to your wall. This is your oxygen inlet for this one. This is your reservoir bag. You have your valve down here so that you don't compromise your FiO2. And then you have your valve up here. On this one, now, this is a different kind of reservoir. This is the tubing here is actually a reservoir.
Tanks.
You notice that your oxygen
No, that pressure.
tubing goes right through here. So what's going to happen is the exact same thing. Once the the oxygen completely fills this bag, the excess oxygen is going to spill over into this tubing, and this tubing is pre-designed to give you enough oxygen, enough excess oxygen in here, so that when you squeeze this bag, it's going to fill with 100%. So this is a reservoir. This is a reservoir. They're just different kinds of reservoirs. You have that look on your face.
Oh, because let's ask me when you hook the oxygen to the wall, what would you use? But it would be whatever FiO2 the patient's getting. You'd have to put it on, right?
100%.
Oh, always
Always
100.
100%. When you hook this to the wall and turn on the flow meter, what's coming out of that flow meter?
100.
100%. The only time you're going to have a lower FiO2 is if you take the reservoir off. Then you have a lower FiO2. You understand?
Yep.
Okay. Everybody?
How much liter flow do you crack
15,
that?
it's like 15, right, all the way?
For the adult, 15 to flush. Remember we talked about if you put it on flush, you're getting about 23 liters per minute through there. It only goes up to 15, the numbers you can see, but if you can keep going with that dial and it'll keep going, you'll keep you in the flow getting louder and louder. It can go up to like 23 to 25 liters per minute, and you'll hear it. You really only need 10 to 15
For the pediatric one? Or
for the adult.
Oh, no.
For the pediatric, I would say about 10, and for the neonatal, I guess about 10, 8 to 10. I don't know, depends.
So there's really no like set one.
Because you're getting 100% oxygen out of the wall regardless.
Regardless, you're going to get it. Anytime you turn that flow meter on, you're getting 100%. It's only the air entrainment that's going to give you your different FiO2, depending on, no matter what device you're using. Okay, so this is a reservoir, this is a reservoir, all of these are your reservoirs. You know how to put your manual resuscitator mask. The masks are made of a clear plastic material. They're clear so that you can visually see through what's going on in here. You're bagging your patient, and you really want to be able to see if there's any mucus, if there's a loose tooth, if there's blood, so you can physically see what's going on in there. They all come with this nice soft cushion around it so that you can get it to fit over the patient's face, and you want to get a seal. You don't want to have a leak around the patient's face because you want all of the air going into the patient. You don't want it coming out around the face. You're going to use, if you look in your book, I'm sure you have already, you do what they call the EC method. You make an E with these 3 fingers and a C with these 2 fingers. You're going to go under the bony prominence of the jaw, and you're going to use the jaw lift method because you have to open the airway. If you do this and you're pushing your face down, you're closing the airway. You're not ventilating your patient. You need to open the airway. You want to not overextend, but you want to extend the neck a little bit. Do what they call the sniffing position. Just look like they're sniffing a little bit. It's anatomically shaped so that this portion goes over the bridge of the nose and this one goes under the chin. You don't want to go into the soft tissue here because you think about it. When you push in here, you're choking the patient. You want to make sure that you're on the bony prominence with these 3 fingers. Then you're going to go around the mask like this with these two fingers, and you're doing two things at the same time with one hand. You're opening the airway by pulling up on the jaw, and you're pressing down on the mask at the same time. Trust me, your hand can get real tired after a while. And then C. And then you want to make sure that you're seeing chest excursion. How do you know what volume you're giving your patient? You don't. You want to see a good chest. You don't want to hyper. You don't want it like blowing up. And you just want to see a good chest excursion, and that way you know you're ventilating your patient. What I do, especially when I'm bagging my little people, is I'll ask somebody to listen to breath sounds to make sure I'm moving enough air. And you want to see chest excursion. How fast do you go to bag?
Whatever the patient's respiratory
Yeah.
rate
About, 16, 12 to 20 breaths per minute, because you want to make sure you give them time to exhale. Okay? You want to press in, see chest excursion, allow them to exhale.
So
You don't want to hyperventilate. And you know what happens? You get to a code and the whole adrenaline thing kicks in and you find yourself doing this. You're hyperventilating your patient. You don't want to do that. That can be as dangerous as not ventilating them at all, because you're blowing the CO2 off too fast. You want to make sure that you're allowing them to exhale. And if you don't have a seal, then the patient's not getting it.
So you pretty much you're just watching the
You're
chest
watching
rise
the chest
and
rise.
go down, and that's when that's going to be like your kind of cue when that's when to
Right,
pump
because you
it.
want to see that chest
and you
rise.
don't want to see their stomach rise.
You're going to see a little, some of the air is going to go in the stomach, but you try that by keeping the airway up and by not pressing too hard and too fast, it prevents you from putting too much air in the stomach, because you don't want them to regurgitate on you. You'll be standing there and you're bagging, and all of a sudden you're going to see it coming up. You got to be quick on your feet, turn them to the side, so that you don't get it all over you.
And they don't get it back and aspirate.
Yeah, and you don't push it back. Yeah. Okay.
Hey, Mary.
Huh?
I got to bag somebody, but